Welcome to the webinar on tricuspid valve regurgitation. My name is Maurice Sarano. I'm a senior scientist at the Minneapolis Heart Institute, and today my co-host is Professor Julia Grapsa from St. Thomas Hospital and King's College. And we have today an expert panel from both sides of the Atlantic, including Professor Francesco Maisano, from Milan, Dr. Maurizio Taramasso from Zurich, Dr. Nicole Karam from Paris, and Dr. Alison Duncan from London. So today we are going to be presenting with my co-host Julia Grapsa, editor-in-chief of JACC Case Reports, a case series on tricuspid regurgitation, not just one, but a series of cases and case reports and case series about tricuspid regurgitation and the various aspects from the medical treatment to interventional treatment. And we will review the cases that we have published, that are going to be published in JACC Case Report. And this has been gathered in cooperation with the PCR Tricuspid Focus Group. And so before we start, maybe I can ask Dr. Maisano if he can say something about this focus group and the goal of this focus group on tricuspid valve regurgitation.
So thank you, Maurice. First of all, it's a pleasure to have this discussion across the ocean. PCR Focus Group was established 2.5 years ago, and it was really stemming out of a need for gathering together experts from all over Europe and United States around the tricuspid disease. Initially, we thought that the awareness about this disease was very below expectation. And we also thought there was a need to establish some degree of alignment between different specialists. So the PCR Focus Group actually is a multidisciplinary group of people. More than 80 experts have been working together for 2.5 years, trying to align ideas, trying to share opinions. And we have been able to basically find some agreement on classification, on imaging discussions, and other features. We've been writing papers together, and we have been able to, more importantly, to discuss about the different aspects of this so-called forgotten disease, which I think is not anymore forgotten. So we are very pleased to work together with JACC Case Reports and work together on this effort.
Excellent. Thank you, Francesco. Julia, you want to say a few words of the cases that we have and on the purpose of this issue?
So, first of all, I would like to acknowledge that this was a joint effort of the two groups, as we said, JACC Case Reports and PCR Tricuspid. And it has been a great issue that's coming to the 19th of April. And this is just a teaser of the cases that we're going to share. And practically, I would prompt people to read more on the actual issue. First, you will see that we have three groups of cases. We'll start from anatomy and physiology. The first case, management of volume overload in severe atrial functional tricuspid regurgitation, improved feasibility of transcatheter edge-to-edge repair. First author, Andrea Scotti, and the last author is Dr. Azim Latib from Montefiore Einstein Center for Heart and Vascular Care in New York. And the authors describe two patients. The first 81-year-old man, for example, who came in with massive edema in decompensated heart failure with a large tricuspid annulus 49.1 millimeters and that he was not a surgical candidate after discussion at the MDT, and he had the aggressive diuresis with IV diuretics and also 2 large volume paracentesis of 14 liters in total, leading to a weight loss of 45 kilos. And the patient was also on, as we said, IV furosemide 160 milligrams once daily, and that was changed to torsemide 100 milligrams twice daily. And you can see here the values of the right heart cath. And the authors practically explain how with aggressive diuresis, we can reduce the tricuspid annulus size and then to make the patients eligible for a TriClip procedure. So here you can see before volume reduction and after volume reduction, how actually the tricuspid annular diameter changes. And as I said, the patient is eligible for a structural intervention. Here is the videos of the second patient that was 81 years old patient that again from the short acts of the TOE, you can see the severe tricuspid regurgitation and how the authors managed to insert 2 clips at the anteroseptal commissure and the second clip at the lateral aspect of posteroseptal commissure. Then the second case, which is under the leadership of Nicole, the first author is Dr. Tanya Puskas, and from Georges Pompidou Hospital in Paris. It has a title Transcatheter Tricuspid Repair for Tricuspid Regurgitation After Heart Transplantation. And here they describe a 67-year-old male patient with severe symptomatic TR, and the patient had a background history of DCM, dilated cardiomyopathy, and he underwent heart transplant, and then following the heart transplant had repeated transjugular cardiac biopsies that ended into this, as we say, iatrogenic, severe tricuspid regurgitation. And the authors describe how actually used transesophageal guidance in order to perform this tricuspid edge-to-edge procedure. And this is very useful for many patients that they experience severe TR after transplant, after actually the biopsies post-transplant. Then the third case is treating the recurrent tricuspid regurgitation and iatrogenic atrial septal defect. Then the first author is Dr. Tilman Kerbel, and the last author is Dr. Martin Andreas from the Medical University of Vienna in Austria. And here they describe how heterotopic caval valve implantation may be a reasonable option for improving symptoms in selected high-risk patients with recurrent tricuspid regurgitation after failed tricuspid valve repair. And also they emphasize that altered right atrial hemodynamics should be considered in procedural planning to avoid potential right-left shunting in cases with septal defects. Then the last case of this group of cases is feasibility and challenges of transcatheter edge-to-edge repair for very large tricuspid valve gaps, similar to the first case series under Dr. Philip Nicolai and Dr. Rafi Bekerenjian from Robert Bosch Hospital in Stuttgart. And the authors again employ this issue that we have when a patient has a large tricuspid annulus, and with optimal medical management and aggressive diuresis, the patient becomes eligible for a structural intervention. So with that, I think, Maurice, we can start discussing about, in general, based on these cases.
That's excellent cases. Thank you, Julia. I'm going to start with the cardiologist here, not the interventional or surgeon person. And Alison, how important for you is that preparation of the patient, that medical preparation to make the patient capable of receiving an intervention or a treatment? What's your view on that?
It's a great question and a quite long answer, I suppose. I suppose thinking about it, you'll need to think about optimizing or identifying and then optimizing the correct patient clinically and identifying the correct patient who's anatomically suitable for a tricuspid valve intervention. So I suppose thinking about it clinically, yes, I think most of the pre-procedural workup should be done when the patient is as euvolemic as they can be, because frequently we get a patient who is in decompensated right heart failure, volume loaded, and a lot of the imaging that is then done is not equivocal to what would happen if we were offloading the patient. So certainly diuretics, which is the mainstay of treatment for patients with right heart disease and tricuspid regurgitation, it's really the only thing we've got, needs to be as optimal as possible. But of course, you know, they can be harmful too. So, you know, there needs lots of careful monitoring of renal dysfunction, also liver function, while you are optimizing the patient cardiologically with the somewhat limited medical interventions that we've got to hand. And then, of course, the patients need to be discussed in a multidisciplinary team format, just to make sure that we've engaged with our surgical colleagues to make sure that these patients are not suitable for a surgical valve intervention before we start thinking about transcatheter imaging and pre-procedural planning.
Excellent. I'm going to ask now the interventional people to tell us how often a patient may appear untreatable, and then with a treatment you make those patients treatable, in particular with the clip. Nicole, if you want to start on this issue, and then we'll have the whole panel comment.
Yeah, sure. Thank you. So, of course, we have all seen those patients coming over with what seems to be a non-treatable tricuspid regurgitation, and it's quite important to always assess the patient after real depletion. I mean, most of the cases, I just wait for the creatinine level to rise and for a little renal failure to appear to consider that we are ready for the TE. And it's very important not to perform the TE as long as we are not sure that the patient is completely overvolemic. Otherwise, we'll have to repeat it, or otherwise we will just decline the procedure from patients who can have it. So
Francesco, Maurizio, what's your view on making the patient treatable?
Yeah, it is a very important point. We learned in the last few years that you can make untreatable patients treatable, but there is one word of caution. Once you make them treatable by really aggressive diuretic and sometimes inotropic therapy, you should keep these patients under strong diuretic therapy, and sometimes even inotropic therapy, to avoid single leaflet attachment in the next days. So these patients are obviously beyond the limits, and I think we learned how to treat them, but still the right ventricle is a very fragile system that needs to be supported for at least few weeks after the procedure. So they remain high-risk patients.
High-risk patient. Maurizio?
I totally agree with the concept that Francesco and Nicole already said. I would just to add that there are not only extreme patients that are untreatable that we can optimize to make them treatable. Sometimes there are patients that are challenging with not such an extreme gap, and it's anyway a good practice to optimize them to reduce the gap. So the concept of optimizing patient apply, in my opinion, not only to these extreme patients, but overall to all patients. If you can bring them as much optimized as possible to the procedure, in any cases, this is making our life easier, and probably also the repair more durable, because we can get more leaflet insertion during the procedure.
Excellent. Julia, any comments, any question you have on the subject?
No, I think as we discussed, Maurice, that these are patients that they are, they have heart failure, so they're maybe elderly patients. And as we are making them treatable, we need to keep in mind, as people said, that we need to keep the medical therapy so we should actually discuss with the patient, provide their expectations, make sure that they don't think that this is a miracle. It is in conjunction with optimal medical therapy. And of course, this is a life-saving treatment when we treat the tricuspid. But I would like also to ask, if you don't mind, how important is periprocedural imaging about this? We saw, for example, Nicole, the heart transplant patient that had so many biopsies that practically they managed to implant their triclip. Or we saw the case that when we used the tricuspid annulus in order to implant. So may I start with Alison about the role of periprocedural imaging and how important it is to select the right approach and the right actually commissure that will implant the triclip or any other, of course, structural intervention.
So thank you very much. So absolutely, as soon as we've identified the correct clinical patient and we've optimized them, then the pre-procedural imaging is the next stage. But I must say it's a vital, if not, a completely a substantial part of the clinical workup for many reasons. First of all, it's very important to try and identify the anatomy of the tricuspid valve. Because the tricuspid valve morphology is very variable, and it's important to know how many leaflets or how many scallops or any folds or indentations, because this very much influences the ease or difficulty of particularly edge-to-edge repair, and can have an association with the outcomes. It's also very important to classify the etiology of the tricuspid regurgitation. So the tricuspid focus group is working very hard at the moment, and there's a fantastic paper in Neurointervention from 2021 from the group describing the classification into primary and secondary tricuspid regurgitation, and within secondary to try and decide whether it's an atrial etiology or a ventricular etiology. And then there's a separate third group related to the cardiac implantable electronic pacemakers. So that's important to understand the etiology of the tricuspid regurgitation. And then a third side is to determine the severity. So not just the severity of the tricuspid regurgitation, to manage the implant team and the patient's expectations of how much reduction can be achieved, but also to look at the severity, if present, of any right ventricular dysfunction, again, to manage expectations, to understand the potential benefits from the procedure. And then I suppose the fourth side of it is to look at the practicality or the feasibility of any tricuspid valve intervention. So if you're looking particularly at edge-to-edge intervention, we need to look at the coaptation gap, and now what's now commonly known as the treatable gap. So if there is a preclusive large gap in the middle of the valve, is there a treatable coaptation defect somewhere else that we could start with and perhaps zip the valve closed? What do the leaflets look like? Are they restricted? Are they pulled down? Are they tethered? Where is the position of any pacemaker? If we're thinking about an annuloplasty, what is the size of the tricuspid valve annulus, which is where we bring in imaging modalities other than echo, so particularly CT, and looking at the course of the right coronary artery. And then if we're looking about transcatheter tricuspid valve implantations, again, about the annular size, the angle of the IVC coming in, and potentially the dimensions of the vena cava. So imaging is fundamental, it's multimodality, it's inclusive within the heart team. It's important that the interventional team understand the imaging as much as the imagers can provide the imaging to help guide the procedure. So it's an absolutely vital stage of the workup for transcatheter tricuspid valve intervention.
Wonderful, Alison. We've been joined by Dr. Paul Sorajja from the Minneapolis Heart Institute. Paul, we were talking about the patients that were initially judged untreatable and then become treatable with medical treatment. How is that in your experience? Have you made a lot of patients untreatable, from untreatable to treatable by the tricuspid clip?
Well, thank you, Maurice, and thank you for the opportunity to be here. What I would say to that is that, there are patients that respond to medical therapy, and optimizing them ahead of procedures from a diagnostic as well as a therapeutic standpoint is really important. And so there have been, of course, patients in whom we just cannot get there, but it's actually less common than more common. I would say most patients being able to get there, and sometimes it's a matter of bringing patients in for hospitalization and IV diuresis. I think, a LASIK strip goes a long way for these patients.
Excellent. Then the last point of this part of the session is the various etiology. Nicole, you had this patient, you presented those cases with ruptured cord, post biopsies. Do we treat every kind of etiology, or there are patients who make you pull back and say, no, I don't want to treat these patients?
I mean, it's all about, again, totally agree with Alison on the importance of imaging. So it's not really what is written on the paper regarding the etiology, but it's really about the feasibility. So we understand them if we are talking about edge-to-edge repair. So the idea remains if we have enough leaflet length, enough leaflet motion that is available, good imaging, because this could be a sufficient reason to say that we cannot do this procedure if we don't have enough good imaging. In the particular case of transplant patients, it's very important to understand what was the mechanism of the leaflet of the tricuspid regurgitation. If there is too many leaflet damage, in some cases it's beyond therapy, at least with edge to edge. So here, imaging is really, really, really important to understand if we can do something about this case. So yeah, it's not really the name of the etiology, but the leaflets, the gaps, the prolapse, the height. That's what makes the difference.
Excellent. So maybe we have spent a lot of time on the medical treatment. Julia, should we go to the next series of paper?
So thank you, Maurice. The second group of cases that we have is under pacemaker leads, and the first case is tailored treatment of patients with intracardiac leads and tricuspid regurgitation. The first author is Dr. Laura Sanchez, and the last author is Dr. Javier Freija from University of Barcelona in Spain. And here, practically, they describe how, of course, pacemaker-induced TR can be managed through structural intervention. They describe practically a second jet of TR secondary to mild restriction of the posterior segment of the septal leaflet by the pacemaker lead without adherence of the lead to the leaflet. And then on the specific patient, the authors moved the pacemaker lead into the posteroseptal commissure using a tri-clip transcatheter valve repair device, and then tackled the functional TR with an anteroseptal transcatheter tricuspid valve repair device placed at the central part of the valve. Although they describe it, although the posterior clips are usually implanted after the anterior ones to avoid imaging shadowing, the authors decide to start by moving the lead, and then it provides better maneuver and reduced restriction of the septal leaflet when treating this functional TR. So the second case is under Alison Duncan, who is here with us. And the first author is Dr. Rory Duncan from King's College and Royal Brompton Hospital in London. And the title of the case is Iatrogenic Tricuspid Regurgitation Associated with Pacemakers, a case compounded by tricuspid stenosis. This is a very interesting case of a patient who presented with severe TR 20 years after dual chamber pacing. And the authors performed a TOE that suggested ventricular pacing wire adherence to the tricuspid valve and atrial wire prolapse across the tricuspid annulus. And then during surgical extraction of the pacing wires, they demonstrate that there was tricuspid valve commissural fusion and subvalvular thickening, causing tricuspid stenosis, requiring finally a tricuspid valve replacement. So these are two interesting cases that they show us the interaction of the pacemaker leads and, of course, the tricuspid valve. Maurice, the word back to you.
Okay, excellent. This is a very important point because there are a lot of patients with pacemakers, and the tricuspid regurgitation is a frequent problem. Before we start the discussion on how to manage, Paul, would you comment on what's the efficacy of lead extraction in this patient? Should we do it or forget about it?
It's a great question. And so, I think, to improve eligibility, we have to think about extraction a little bit more, but it has to be done in an expert center because certainly we can make things worse, and we often don't make things better. In our series, it's about half and half. And what I would say is that there has to be a careful review of the anatomy. The more impingement there is, and the more adherence to the subvalvular apparatus there is, the more likely that damage to the valve or worsening of TR may occur. And the other thing I would say is that in our practice, we've been sizing these valves ahead of time for the extraction because what I don't want to happen is we do an extraction and the patient become ineligible for TriClip or tricuspid TEER and then not have a TVR option. So we try to have a backup in the event that we make things worse.
Very good. I'm going to ask the two surgeons, Maurizio and Francesco. When you see a patient coming with complex lesion associated with pacemaker, is it not an easier thing to go to surgery in those patients than doing a very complex intervention? What are your thoughts on that?
Maybe I can start. I would say first that not all the patients with pacemaker lead are complex intervention. The majority of them, they are easy treatable with TEER with no issue. And, you know, in all real world registry, up to 30% or even more than 30% of the patient has concomitant pacemaker lead, and it has been demonstrated that it is feasible. So overall, it is not a contraindication. So it's not something that make you generally think to an alternative treatment. And then, as you said, there are some, let's say, complex situations, which are the minority. We should be able to identify them. There are some tricks. One is the one that we have seen, for example, in the first case presented, to basically jail the lead with a clip to isolate him and to minimize the interaction between the lead and the leaflet. Paul published or reported few months ago another trick by using a steerable catheter to move during the implantation temporarily a lead and then to implant the clip. So there are several tricks that can be used to make, but again, this is just a minority of the cases. And then obviously, if there is no option at all, then, and the patient is a surgical candidate, this could be considered, but keep in mind that soon a replacement option will be available, and most of the replacement device are implantable in presence of a pacemaker lead. So yeah, alternative treatment are an option, but I think in a really selected patient, TEER is really not feasible in presence of pacemaker lead.
Francesco?
Yeah, Maurice. So it's difficult to put. I have to put my surgeon's head to put a word of caution. So first of all, surgically we can actually manage leads pretty easily. We can extract leads with minimal impact on the leaflet anatomy. We can somehow push the leads in the commissures and jail them in a commissure in a way that they will not be damaging valve function. So there are many things that can be done surgically. As usual, surgery can be excellent in many occasions. On the other hand, we're talking about patients who are seldom referred for surgery. And I agree with Maurizio that most of the patients who have been classified as CID related TR, most of them, they just have concomitant TR in presence of a lead. And I think we did a webinar with the HERA, with the European Association for Heart Rhythm Management. And this is one of the magic effects of the PCR focus group. We did this webinar together with the electrophysiology people, and there is a growing interest into right ventricular desynchrony. So many of these patients who are right ventricular paced, they also have right ventricular desynchrony, which is associated with tricuspid regurg. And the solution will be in the future maybe more physiologic pacing. We're talking about his bundle pacing, which is going to be another complication in the system, because as we will discuss maybe later, you know, his bundle pacing means you have a lead which is really the anteroceptal commissure. So overall, the full field is moving in many directions, but the main point is that we are aligning our knowledge and trying to better understand right ventricular dysfunctions and the tricuspid disease. So surgery remains an option, but I would say, as I look at in the future perspective, it's going to be always less and less of an option.
So maybe I can ask Nicole something. You know, we have you all experts here, and knowing what you're doing, but it seems to me very complicated to move a lead, to displace, to put a clip exactly at the lead. Is it for every interventional team to be able to treat this kind of tricuspid, or you see tricuspid and pacemaker and you say, okay, it may be complicated, maybe it's better to work with an expert center and a limited number of people who can do it? What's your thought about it?
No, I guess these are particularly complex procedures when we are coming to the point where we have to move the leads. Then here we need to have both on the same side an expert team for the valve, but also an expert team for EP. I've done one case today of moving the lead to place the clip. And you know, at every step of this procedure, you are afraid for your lead. You don't want to completely remove it. You really need to have somebody who has an expertise with the feeling of this is too much tension, the leaflet is tearing too much, the lead is tearing too much. So you really need some expertise. Anyway, it is for tricuspid procedures. I think that we need to have expert centers to get to tricuspid treatment, and here we are moving a step forward. And I guess leaving this in centers with capacities of having a good EP and a good valvular team is very important.
Yeah, and so I'm going to ask this question to everybody: is you know, the temptation is to throw a clip at the patient with TR and maybe leaving the patient with a lot of TR, and so these intervention to me sound complex enough, and we want to have a perfect result. How do you see that playing in the world of cardiac intervention? I let you decide who wants to speak first about this distribution of cases.
I want to speak first here. You know, we have been discussing that reducing TR is already associated with good results, but the Triluminate trial showed us that there is a dose effect. So, as usual, there is always an advantage when you reduce compared to baseline. But the best effect is to abolish TR. If we were able to abolish TR in every patient, it's going to be the best treatment possible. Now, the question is whether you can do it in every patient, and the other question is whether every physician at the beginning of their career, their learning curve, is able to do that. So, in future, probably this will become a widely available technology. But at the moment, I would really suggest to refer these patients to high volume centers to obtain the maximum effect. We all have been, in this webinar, you only have people who have been involved in the early stage, and we have been accumulating enough experience. What we see now, still people in the learning curve. It takes time to obtain excellent results in terms of patient selection, patient preparation, and interprocedural performance.
Let's say we were talking about Triluminate, and Paul, I would like to have your comment on Triluminate, and everybody's excited about the results, but also having many questions. What do you think?
Oh, I think there's a lot of questions. I think, there's always controversy in every trial, and you can always poke holes at all the weaknesses. No trial is ever perfect. All I can say is that I think we worked extremely hard to have a trial that's as rigorous as possible, to focus on the effects of TR reduction itself in the context of whatever other morbidities they were. And the results are what you found. It's different. It's right-sided, not left-sided. And there's still a lot to that too.
Okay, very good. So maybe we have spent already quite some time. So do you want to talk about the last cases, Julia?
Yes, so we have, thank you, Maurice. So we have two last cases that they describe actually the future in tricuspid structural interventions. So the first is a transcatheter tricuspid annuloplasty in a patient with very long segment of right coronary artery proximity. And the first author is Dr. Ángel Sánchez Recalde, and then with the last author, Professor José Zamorano from the cardiology department in Madrid in Spain. And the authors describe practically a new 78-year-old woman with severe symptomatic secondary atrial tricuspid regurgitation and with a long segment of RCA proximity in the posterior tricuspid annulus, that she was treated with a new transcatheter annuloplasty. And the authors describe, of course, the intraprocedural imaging. They have great videos, fluoroscopy and TOE videos of the procedure, as well as a central illustration of the annuloplasty device. And then the next case is a transcatheter tricuspid valve replacement with a novel self-expanding valve and the secure fixation in secure anatomy, as they describe it. The first author is Dr. David Bluestein, and the last author is Dr. Sushil Kodali from Columbia University in New York. And again, the authors have impressive imaging of the delivery system and the self-expanding valve. And practically, they describe how they managed to a 72-year-old male who presented with severe symptomatic tricuspid regurgitation due to anterior leaflet impingement from VSD occluder, placed 2 years earlier, and the patient had the VSD because of a previous TAVI that was complicated by the VSD. And also the patient had Parkinson's disease and rheumatic fever, and of course he couldn't be operated. The authors describe this new valve, and also they have also impressive CT images and also intraprocedural TOE. Thank you, Maurice. Back to you.
Okay, so we have the discussion about annuloplasty, which is in surgical hands, annuloplasty had a recurrence rate of 25 to 40%. So, you know, we were always hesitating in doing annuloplasty in patients with TR. For the prevention is great, but for the treatment of TR, there is a lot of recurrence. So is it reasonable to do percutaneous annuloplasty in those patients? Francesco is really interested in responding to that.
It's obviously is a good question, and I take it happily. So basically, I agree with you. Whenever you have tethering, mitral and tricuspid, there is no way you can treat tethering with annuloplasty. You only increase tethering, which means when you apply annuloplasty in patients who are eligible for other procedures like a replacement or even edge-to-edge, then you have a better result. On the other hand, don't forget we are treating many patients with heterogenic, so-called heterogenic TR. We're treating patients earlier and earlier, and therefore I see an option in the future for annuloplasty. The problem is not the efficacy. At the moment, the problem is the complexity of this procedure. It is a procedure which takes probably 3-4 times the time it takes for edge-to-edge, even replacement. Maybe second, third generation annuloplasty devices will become available in the next 1 or 2 years. And this will make this procedure easier and more, let's say, reproducible in the larger community. I still believe annuloplasty in early intervention may play a major role because it's the single procedure that leaves the minimum footprint for future possible interventions. So, but obviously this has to be supported by real-world experience.
Alison and Julia, I'm going to ask, we're the medical cardiologist. So we wish to have, my wish is to have zero residual. There has been a lot of discussion about the pop-off valve and leaving a little bit of regurgitation. What do you think about having zero residual TR? Is that your goal? And how do you see the percutaneous valve replacement in the future?
Well, I mean, if I might take it first, I think Francesco mentioned it earlier on, and Paul, a dose effect of reduction in TR. And I think what you have to try and remember with this group of patients is that, you know, their symptomatic improvement with even 1 grade reduction can be really phenomenal, and it can also open the door to much more optimization of medical treatment. So I think potentially, unlike the surgical community, at this moment in time, the transcatheter community, while the ultimate goal is achieving 0 regurgitation across both the left or the right AV valves, I don't think it's so symptomatically important on the right AV valve at the moment, the tricuspid valve, because if we can get a reduction of at least 2 grades, the patients feel symptomatically so much better, and they have much more improved cardiac output, and their energy levels and their quality of life improves so much that we don't actually at this moment in time need to give them 0 TR. But I suppose conceptually, if we were able to do that, then presumably the outcome will be better. But on that note, what we also don't know at the moment is that we don't see a right ventricular afterload mismatch type phenomena that might occur, that happens on the left-hand side fairly frequently when you put a transcatheter mitral valve implantation in. We don't know what's going to happen to the right ventricular function after complete obliteration of TR. That's not really that well experienced just yet. But what we do know, and it's absolutely been proven again by the Triluminate study, is that patients feel better with reduction of their TR. It doesn't have to be obliterated.
Julia, what do you think? Complete suppression or partial suppression?
I agree with both. I couldn't agree more with Alison. And actually, I was very enthusiastic when I heard the results of the Triluminate by Paul, because as an imager, you know, it's very difficult to achieve, of course, 0 regurgitation. And as Alison says, even 1 grade of reduction, you see the patients then thriving, and you see from the next day that they are so much better. So if we keep in mind that you know, optimal medical management and then the tricuspid intervention will make a difference for our patients, I think we are giving them now hope when there was no hope before. And as Alison said, that also, you know, to assess RV, to bring patients to the tertiary centers much earlier, because we used to have general practitioners sending the patients too late for us to do something. So all these, you know, that's the purpose of of course, the PCR Tricuspid Focus Group, and also our efforts as physicians to these patients.
All right, so let's discuss the heart failure
Paul wants
issue.
to say something.
And so I'm gonna give the microphone to Paul, but let me ask a little bit. Do you think that heart failure hospitalization may be not the right measure in people who have heart failure due to TR, because these patients stay for a long time outside, and that's a different form of heart failure than left-sided valve disease? So what are your thoughts about that?
Yeah, I think it's entirely different. You know, I think that what brings a patient to the hospital for left heart failure is pulmonary edema. And the equivalent on the right side of lower extremity edema doesn't bring people to the hospital. You may come in for IV diuresis, what have you, but it's just not the same. It's not the same urgency. And you know, certainly COVID probably affected our heart failure hospitalization rates in Triluminate. I think we can all accept that, but it didn't explain everything. You know, we did a sensitivity analysis, and it wasn't clear that it was all related to COVID.
Do you think we should have different measures of the heart failure, like the size of the liver, like the amount of water that we can measure, something different for the heart failure due to TR versus, Nicole, what do you think? And Maurizio, heart failure in those patients, what should we do as an endpoint for future trials? How do we measure the heart failure of patients with TR?
Yeah, I guess it's a very good question. I'm not sure that I have the absolute answer to it, but definitely it's more than a criteria, and it's definitely not hospital admissions per se that will make the difference. We have seen improvement in liver and in renal function in those patients, with lots of time after the procedure, we can also see a better response to diuretics and maybe a decrease in dose. But as Francesco said, we shouldn't aim for reducing the diuretics dose. But with time, we see that they respond better. We can also take a look at the edema. We can take a look at the ascites. But I guess it's more than one endpoint that we have to have.
Maurizio, what's your experience with the heart failure, with how to assess the heart failure in patients with TR and assess the result of the intervention?
Yeah, as Nicole said, it's difficult to give an answer. I think at the end, quality of life is a really important parameter, even if it is subjective, I know, but the dose effect correlated with the TR reduction and the improvement in quality of life suggests that there is really an objective improvement. And probably, as you said, we should work together with the heart failure community to make a better definition of what an heart failure hospitalization, let's say, from the left correlate with the right side of the heart. Is not, as Paul said, acute hospitalization because they don't get pulmonary edema. We should measure something else, and this is probably multi-parameter. We still don't have a proper definition for that.
Yeah.
I might go as far as just to say, look, check the blood pressure, because actually people's blood pressure comes up after they've not got, if they've got forward flow from the right side, their blood pressure will go up. And I think you're absolutely right about the sort of the soft signs of the longevity of the buildup of tricuspid regurgitation does require something else from us as a community to identify these patients early, but therein lies the problem, because they are soft signs. The patients feel fatigue, they put on a little bit of weight, they are all getting old, they all attribute it to this. I mean, it might even be something as subjective after your acute early management, as Francesco said, keeping the patients on high dose diuretics for a short time, but maybe it'll just be, the dose of diuretic.
But I think it's very important what we learned from Triluminate. Triluminate trial is giving us some important messages. Number one, these patients have been enrolled in the trial without being hospitalized prior to the trial in most cases, although their quality of life is the lowest in any heart failure trial ever. What we see, their quality of life improves, although we don't have objective measures like 6-minute walk test. The 6-minute walking test could be somehow misleading, because these are elderly patients. You don't know how many of these patients have maybe orthopedic issues. There have been also an adjudication issue that any time a patient was hospitalized, the walking distance was set to 0. And also hospitalization has been highly influenced by COVID. So there are many confounders there. Yeah. What we learned, in my opinion, from this trial, first of all, left side heart failure is not right side heart failure. The endpoints may be different. Quality of life is very bad for these patients and can be improved by the procedure. And improvement in quality of life goes with better digestion, better energy, high blood pressure, like Alison said. And what I love about this trial, and probably I will be wrong in the future, but I'm very happy that not end-stage patients have been included. So the typical netter picture of the patient with liver, with ascites, with liver expansion, with hepatorenal failure, and cyanosis and leg edema, these are not the patients who have been enrolled. And these are the patients who have been treating in the last 5 years. 5 years ago, we were treating only these end-stage patients with somehow suboptimal results. What we believe is that right heart function is as important as left heart function. if you have inefficient right heart function because of severe TR, you have low cardiac output, which is a chronic disease affecting the full splanchnic area, and therefore your outcome will be, in the long term, you will see the problem in 5 to 10 years. So we had to wait, okay, but triluminate patients hopefully will tell us something in the future. Only drawback of the triluminate trial that crossover is allowed after 1 year. And I'd like to ask Paul Sorajja what he thinks about it.
Yeah, I mean, I would have loved to have a crossover later. There were practicalities in completing the trial, and honestly, there was also the belief that we weren't sure we were going to see a survival benefit even at 2 years, and I think we actually were right on that, because I don't think we're going to see it at 2 years. I think it's going to be 3 to 5. You know, the 1 year cardiovascular death rate for patients with torrential TR and most of the medical arm was 4.7%. I mean, that's at 1 year. Even if it doubled at 2 years, I don't think you're going to see a difference between the two arms. So you're right. The 1 year was okay. It would have been nice. Would have been nice maybe to consider a sham, but I don't think there's a placebo effect. And I think that regardless, it's going to be a few years before we see differences. The great thing is we know that these patients at the start were hugely different in terms of severity of TR. And I cannot believe as a physician that severe symptomatic torrential TR doesn't affect somebody in some way in the long term. And the imaging sub-study that Joao Cavalcante is leading is going to help with that, because we're going to see, I believe, CT, MRI remodeling characteristics that'll be different, and we'll find out. We'll find out between the two.
Maurizio, if you see RV dysfunction as part of that heart failure, what's your assessment of the patient? Do you judge by eye? What marker of RV dysfunction do you use in your practice to say this patient is a good patient for treatment of TR and this patient is not a good patient to treat for TR? And how does that contribute to the heart failure?
Yeah, again, I do not have a clear univoc answer. It's a multi-parametric assessment. Obviously, you look at the morphology. You look at several parameters, including TAPSI, which is probably the easiest, even if it is not really accurate in assessing the function in severe TR. You look at the shortening fractional area of the ventricle and to the longitudinal strain. But most importantly, probably is the coupling of the right ventricular function with the pulmonary pressure. So if you have a favorable coupling, that means that you most likely have a reserve and there is space for improvement if you reduce TR. If the coupling is unfavorable, then most likely those patients won't have any reserve. So I'm really looking forward from the result of the sub-study, the imaging sub-study, the triluminate, because I think we will get a lot of information from MRI on those patients, and probably we will learn better how to select patients according to the RV function from this.
Have we forgotten something, Nicole? Have we forgotten to discuss something about TR?
I guess we can keep going for hours if you want to discuss everything about tricuspid.
I think one point I'd like to mention in this, obviously this is not a triluminate webinar, but it's very interesting to mention that in the triluminate trial, the medical therapy arm showed no improvement in TR at 1 year. This is pretty uncommon, in my opinion, because we all believe that this disease can be easily managed by medical therapy.
If I can intervene on that point, we've done tons of diagnosis of TR, treatment, reimaging, and you're so happy after 1 week of treatment where the patient is looking good, the TR is markedly reduced, and then a month later, the patient is back with the same TR, you continue the treatment, and they don't absorb the medication, and they go downhill. So we have a very narrow moment with the medical treatment, and then the long term, the 1 year, they're in bad shape, and they're not doing very well. So we've seen the limits of medical treatment as a very temporary improvement, which is good. We can improve the patient temporarily. It's always good to have, but it's not something that is sustained, and we're glad that Triluminate shows that.
Yeah,
Can I just add to that? What's really interesting is that there were 1,500 patients screened for Triluminate, and interestingly, of the patients who were not enrolled, 51% failed screening. The most common reason for failed screening enrollment into Triluminate was the fact that TR was not severe; it was only moderate.
Huh. Yeah, it's very misleading because sometimes, you know, the imaging is very difficult for TR because you see a large jet, but it's blue and it's not impressive, and you hesitate in saying, okay, is it severe? And for people who have decreased their pressure in the right ventricle or have low pressure, it's a TR at low pressure, the jet is very unimpressive, and we should be very careful in saying moderate when these patients may have very severe TR and sometimes have reversal in the hepatic vein. So the imagers, a word of caution that we have to be careful in calling moderate TR in those patients.
I think this is a big shout out to Becky Hahn's actually extended grading system, because this is a well-used tool in transcatheter land, but it is still not widely used in outpatient diagnostic transthoracic echo screening, nor in the surgical world. And so when people say severe to one group, that means one thing, and it means something else if you're a transcatheter interventional doctor. So I think it would be great, and that's one of the brilliances of the the PCR focus group for tricuspid, is we are talking, we're engaging, and we're bringing in new groups. So to try not just to spread awareness, but to gain alignment across many different medical subspecialties, so that we are all talking about the same disease with the same type of language. I think that's a really crucial point.
That's a very
chime in on that. It's really interesting because the reason why I was late to this webinar is because I just finished a Triluminate case, and the patient had torrential TR, grade 5. It was super complex. It was a starburst coaptation. I think a lot of people would have replaced this valve, but we got the patient from grade 5 to grade 3, and I thought about continuing on, but I was worried of just messing up my acute results. But I know from Triluminate that 2-grade reduction should afford at least an 18-point improvement in quality of life. And so I elected to do a wait. And but that's all because of Becky's all because of Becky's 5-grade scale. If I were going just based on severe alone, I would have been confused and lost as to what to do. And so taking out what you're saying about taking that sophistication further in a diagnosis and therapy of what we do is so important. I completely agree with you.
Yes.
So, Maurice, I think we are 1 hour and 15 minutes now. I think we should find conclusions. Otherwise, it's not gonna be working.
We can talk the whole day. One point that I want our attendees to remember is that TR is severely undertreated. We treat 5% of the patients who have TR, and our common task as physician, is that these patients are brought out of the shadows and treated for TR, whichever way we treat them, to decrease, to eliminate, but to diagnose them correctly and to reduce this bane that we have of under treatment or very reduced treatment of tricuspid regurgitation. And I think that, Julia, if they want to look at the issue of JACC case report, there are very diverse cases that we can look at and that we can learn from. Thank you so much.